Welcome to the deep dive. If you've got a furry family member, especially one, getting on in years, you might have heard about kidney issues, maybe even dealt with them.
It's pretty common, unfortunately.
Yeah. And today we're going to unpack a specific complication of chronic kidney disease in dogs and cats. Renal secondary hyperparathyroidism. It's a bit of a mouthful.
It is, but it's important.
Definitely. Stick with us because understanding this sort of domino effect can really help with your pet's well-being.
Exactly. Think of this as a look under the hood. What happens when kidney function declines? Our goal is to take the expert info we have and just make it really clear.
What triggers it, what it does, what can be done.
Right, and we're using resources focused specifically on managing this in pets. So, solid information.
Okay, let's dive in then. Renal secondary hyperparathyroidism. What's the basic idea here?
Okay, so picture like a balance beam. Healthy kidneys keep minerals in the body balanced, but with chronic kidney disease, that balance gets totally thrown off. Renal secondary hyperparathyroidism is basically the result of having way too much parathyroid hormone PTH floating around because the kidneys aren't working right.
And the renal secondary part just means it's because of the kidney problem.
Precisely. It's a secondary effect of the primary kidney issue.
Got it. So how does that initial kidney problem actually lead to the high PTH? What's the sequence?
Well, the kidneys do a lot more than just filter waste, right? They handle key minerals like phosphorus, and they also make an active form of vitamin D called calcitriol. When the kidneys start to fail, they can't get rid of phosphorus efficiently. So phosphorus levels in the blood start to climb.
Okay, high phosphorus.
And that high phosphorus triggers the release of something called FGF23, fibroblast growth factor 23.
FGF23.
Okay. Think of FGF23 as like an alarm bell, and one thing it does is it tells the kidneys to dial back on making calcitriol.
So high phosphorus leads to low calcitriol because of this FGF23 thing.
You got it.
Wow.
And that's where the dominoes really start falling for PTH. Because a couple of things happen. Low levels of ionized calcium, that's the active usable form in that high phosphorus we just mentioned, they both directly tell the parathyroid glands in the neck to pump out more PTH.
Ah, okay. Direct signals.
Yeah. Plus, calcitriol normally acts like a brake on PTH production. So when calcitriol is low, that brake is off, or at least much weaker.
So it's a double whammy. The minerals are telling the glands to make more PTH, and the thing that usually stops them isn't working either.
Exactly. Low calcitriol, low ionized calcium, high phosphorus, they all push the parathyroid glands to make more and more PTH.
Right. And what's the actual harm in having all this extra PTH circulating? What does it do?
Well, the PTH is desperately trying to fix the calcium balance. Its main job is to raise calcium levels. So it starts pulling calcium out of the bones.
Oh, that doesn't sound good.
No, over time, that constant withdrawal weakens the skeleton. PTH also tells the kidneys, hey, get rid of more phosphorus. But the kidneys are already struggling, so they can't really respond effectively.
So it's trying but failing.
Right. And this constant stimulation actually makes the parathyroid glands themselves get bigger. That's called parathyroid gland hyperplasia. They bulk up trying to meet the demand.
Wow. And I think I read somewhere that PTH itself might even act like a toxin at these high levels.
Yeah, that's a growing area of concern. Some research suggests these really high PTH levels might contribute to that general uremic feeling, the sickness that comes with kidney failure.
So not just bone problems.
Potentially not. There's also a possible link to something called nephrocalcinosis.
Which is?
Calcium deposits forming in the kidneys, which obviously could make the underlying kidney disease even worse. It's a bit of a vicious cycle.
Okay, this sounds like something owners dealing with CKD should definitely be aware of. Does it affect dogs and cats equally? Any particular breeds or ages?
The sources confirm it definitely affects both dogs and cats. As for specific breeds or ages, it really ties back to the risk factors for chronic kidney disease itself.
So older pets are generally more likely.
Generally, yes. And certain breeds might be more predisposed to developing CKD in the first place, which then puts them at risk for this secondary complication.
Okay. So if my vet is worried about this in my pet, what signs might I actually see at home? Is it different from the usual kidney signs?
That's a really practical question. Often, the signs you notice first are just the typical kidney disease signs: drinking more, peeing more, maybe not eating as well, losing weight, being lethargic.
The usual suspects.
Exactly. But in more severe cases, especially sometimes in younger dogs that get severe kidney disease early, you might see something called renal osteodystrophy.
Osteodystrophy.
Bone problem. Yeah, bone problems caused by the kidney disease and the PTH imbalance. It can sometimes lead to what's graphically called rubber jaw.
Rubber jaw, what does that mean?
It means the bones of the jaw, particularly the mandible, become so demineralized and soft that they literally feel flexible or rubbery. It's quite dramatic when it happens.
Wow, okay, that's striking. Are there other, maybe less obvious bone-related signs?
Yeah, sometimes it's more subtle. The pet might just seem painful around the head or face when you touch them. Or maybe they're generally more reluctant to move, jump, or play like they used to. That can indicate general bone pain.
Okay. Worth watching out for then, even if it's subtle.
Definitely. That pain can really impact their quality of life.
We know chronic kidney disease is the main cause. You mentioned the mineral imbalance. Does diet play a role beyond just general kidney health?
It absolutely can. The information points out that diets excessively high in phosphorus can be a contributing risk factor.
Makes sense, since the kidneys are struggling to get rid of phosphorus anyway.
Exactly. Feeding too much just adds fuel to the fire, so managing phosphorus intake is really key.
Okay, so let's shift to diagnosis. If the vet suspects this, how do they pin it down? What else could look similar?
Diagnosis needs care, because other things can cause wonky calcium or kidney values. One big one is hypercalcemic nephropathy.
Okay, what's that?
That's where high ionized calcium actually causes kidney damage. It can sometimes be confused with long-standing renal secondary hyperparathyroidism, especially if something called tertiary hyperparathyroidism develops.
Tertiary, what's that?
That's when the parathyroid glands have been stimulated for so long they just keep pumping out PTH even if calcium levels creep up. They become kind of autonomous.
Ah, okay, so how do you tell the difference between that and the original secondary type, or this hypercalcemic kidney damage?
The calcium levels are the big clue. In hypercalcemic nephropathy, the total calcium is usually high, and crucially, the ionized calcium is high.
The active form.
Right. But in renal secondary hyperparathyroidism, the ionized calcium is usually low or maybe low normal, even if total calcium is variable. That ionized calcium measurement is super important.
Got it. What else causes high calcium that needs ruling out?
Well, there's hypercalcemia of malignancy, cancer.
Right.
In those cases, the PTH level itself is usually low, suppressed by the high calcium. But you might find high levels of a related protein, PTH-RP, PTH-related protein.
And certain cancers are known for that.
Yes, things like lymphoma or anal sac adenocarcinoma in dogs can produce PTH-RP. Then there's also primary hyperparathyroidism.
Where the problem starts in the parathyroid glands themselves.
Exactly. They're just overactive on their own. Initially, you see high calcium, often low or normal phosphorus, and high PTH. Kidney damage can happen later because of the high calcium.
Okay, so lots to differentiate. It sounds like blood tests are absolutely central. What do you typically see on a standard panel?
Yeah, basic blood work and urine tests give you starting points. You'll usually see azotemia, that's the buildup of kidney waste products.
BUN and creatinine going up.
Right. And very importantly, hyperphosphatemia, high phosphorus. The urine is typically dilute, low specific gravity, showing the kidneys aren't concentrating well.
And the total calcium.
That can be tricky. It might be low, normal, or sometimes even a little bit high. It's not the most reliable indicator on its own.
So the standard tests point towards kidney disease and high phosphorus, but maybe not definitively to this specific PTH issue.
Exactly. To really nail the diagnosis, you need more specific tests.
Like what?
The absolute key, according to the experts, is measuring the serum PTH concentration directly. You need a specific, validated test, an immunoassay, designed for either dogs or cats.
So you measure the hormone itself.
Yes, and finding that elevated PTH level along with a low or normal ionized calcium level, that's the classic picture of renal secondary hyperparathyroidism. It really helps separate it from those other causes of high calcium we talked about.
Makes sense. What about things like x-rays? Can they help?
They can provide supporting evidence sometimes. You might see signs of poor bone density overall.
Like washed out looking bones?
Kind of, yeah. Or you might specifically see loss of the lamina dura. That's a thin white line of bone you normally see around tooth roots on dental x-rays.
Ah, okay.
In some cases, you might even see soft tissue mineralization, like calcium deposits showing up in the stomach lining or other places they shouldn't be.
Okay, so we've got the definition, who gets it, the signs, causes, and how it's diagnosed. Let's move to a really crucial part for owners. Management. How do you treat this?
Right, treatment. It really builds on the general plan for managing chronic kidney disease itself, But a huge focus, maybe the primary focus for this specific complication, is getting that serum phosphorus level down.
Controlling the phosphorus.
Absolutely. And that usually involves two main strategies working together. First, feeding a prescription diet low in phosphorus, one specifically made for kidney patients.
The therapeutic kidney diets.
Exactly. But often, especially as kidney disease progresses, diet alone isn't enough to hit the target phosphorus levels.
So what's next?
That's when you add intestinal phosphate binders.
Okay, phosphate binders. How do they work? Are they pills?
They usually come as powders or liquids, sometimes capsules or tablets that you give with food. They basically act like little sponges in the gut. Yeah, they bind to the phosphorus in the meal, preventing it from being absorbed into the bloodstream. Then the bound phosphorus just passes out in the stool.
Clever. Are there different kinds?
There are several. Common ones include aluminum hydroxide, calcium carbonate, calcium acetate, and a newer one, lanthanum carbonate. They all have different dosages your vet figures out.
And you're aiming for specific phosphorus levels with these?
Yes. The targets depend on the IRIS stage of the chronic kidney disease.
IRIS stage.
It's a way vets classify the severity of CKD. For stage 2, the goal is phosphorus under 4.5 milligrams per deciliter. For stage 3, under 5.0. And for stage 4, under 6.0.
So you adjust the binder dose to try and hit those targets?
Precisely. It's dose to effect. But you have to be careful not to use too much, and there are some interactions to watch for.
Like what?
Well, if you use binders that contain calcium, like calcium carbonate or acetate, and you also use the other main medication, calcitriol, you increase the risk of developing high calcium levels, hypercalcemia.
Okay. So let's talk about calcitriol. That's the active vitamin D, right? Why add that in?
Right. Remember how low calcitriol was part of the problem? It removed that natural brake on PTH production.
Got it.
So giving very small supplemental doses of calcitriol can help push back against that high PTH. It helps suppress the parathyroid glands.
And what's a typical dose?
It's very low, usually around 2.0 to 3.5 nanograms per kilogram, once a day by mouth.
Nanograms, not milligrams.
Nanograms, yes, absolutely critical distinction. It's a tiny, tiny dose. You usually need a special compounding pharmacy to make it up accurately.
Okay, super low dose. Any special instructions for giving it?
Yeah, typically recommended on an empty stomach, maybe at bedtime, and then no food for about 6 to 8 hours afterwards. Helps with absorption.
But you mentioned needing phosphorus under control before starting calcitriol.
Absolutely essential. You need the serum phosphorus to be within those target ranges for the IRIS stage before you even start calcitriol, and you need to keep it there during therapy.
Why is that so important?
If phosphorus is high when you give calcitriol, you massively increase the risk of calcium and phosphorus depositing in soft tissues. It's called metastatic mineralization, and it's dangerous. You need the phosphorus controlled first.
Okay, so manage phosphorus with diet and binders, then consider adding low-dose calcitriol if needed while still monitoring phosphorus.
That's the general approach, yes. It's definitely a delicate balancing act.
What are the main risks or complications vets watch for with this treatment? You mentioned hypercalcemia with calcitriol.
Hypercalcemia is the big one, especially, like we said, if combining calcitriol with calcium-containing binders. That's why often aluminum or lanthanum binders are preferred if calcitriol is used.
Makes sense.
Also, sometimes pets with really long-standing kidney disease can develop higher total calcium for other reasons. Even if their ionized calcium is normal or low, stopping calcitriol won't fix that type.
Any other major contraindications?
There's a calculation vets sometimes do multiplying the serum calcium by the serum phosphorus. If that product is really high, say over 70, the risk of tissue mineralization is considered very high.
So in that case?
In that case, you'd definitely avoid calcium-containing binders initially. You'd use aluminum or lanthanum binders to get the phosphorus down first. Maybe you could reconsider calcium binders later if the phosphorus comes down and the product is lower.
It really sounds like these pets need super close follow-up. How often are we talking for checkups and blood tests?
You're right. Monitoring is key, especially when starting or changing treatments. Initially, you might be checking calcium, phosphorus, and kidney values like creatinine and urea nitrogen, maybe weekly or every few weeks.
Okay.
Depends on how stable they are and how severe the CKD is. Once things are more stable, maybe monthly.
And what about specifically for pets on calcitriol?
Even closer monitoring at the start. Usually weekly checks of calcium and phosphorus for the first 4 weeks.
Weekly for a month.
Yeah. Then if they're stable, you might stretch it to monthly and eventually maybe every 3 or 4 months. But you're always watching for hypercalcemia or hyperphosphatemia creeping back up.
And do you track the PTH levels themselves over time?
Good question. Yes, checking PTH periodically is important to see if the treatment, especially the calcitriol, is actually working to suppress the parathyroid glands.
How quickly should you see a change?
With low-dose calcitriol, you often see PTH levels coming down towards normal within about 3 months, usually. But if the glands are really enlarged, severe hypoplasia, it might take longer, or the dose might need adjusting.
What happens if hypercalcemia does develop during treatment? What's the plan?
First step is usually stopping the calcitriol immediately. Then you absolutely must measure the ionized calcium.
To see if it's truly high active calcium.
Exactly. If the ionized calcium is high, it's likely the calcitriol causing it, and the hypercalcemia should resolve within about 5 days of stopping the drug.
And if the ionized calcium isn't high?
Then the high total calcium might be due to other factors related to the CKD itself, and stopping calcitriol won't fix it. The approach would be different then.
Are there ways to adjust calcitriol dosing if mild hypercalcemia occurs to try and keep using it?
Yes, the resources mention some alternative strategies vets might try, like giving slightly higher doses less frequently, maybe every other day or even every 3.5 days. The idea is to reduce the impact on intestinal calcium absorption while still getting some PTH suppression. It's complex, needs careful veterinary judgment.
Okay. Thinking about prevention. Can we do anything to stop renal secondary hyperparathyroidism from developing in the first place in pets with CKD?
The main thing suggested is early and consistent dietary phosphorus restriction. Starting that low phosphorus kidney diet as soon as it's appropriate for the stage of CKD might help delay the onset.
So proactive diet management is key.
It seems to be a very important part of delaying this complication.
And if it is managed well, what are the potential long-term problems? You mentioned the bone issues earlier.
Right. Renal osteodystrophy, the bone weakening, is the main one. And in rare, severe, long-standing cases, you could potentially see pathologic fractures where bones break very easily.
That sounds awful.
It is, thankfully rare, but highlights why management is important.
So wrapping this part up, what's the overall outlook, the prognosis, for a pet with both CKD and this PTH complication?
Well, the good news is that managing the phosphorus and the secondary hyperparathyroidism might actually help slow down the progression of the underlying kidney disease itself.
Really? That's significant.
It could be. But we have to be realistic. Both conditions, the CKD and the hyperparathyroidism, if it develops, are progressive over the long term. So the overall prognosis is generally considered guarded to poor.
So the goal is more about slowing things down and maintaining quality of life.
Exactly. Improving quality of life, managing symptoms, and trying to slow the inevitable progression as much as possible.
Okay, so let's try and summarize the key takeaways here. Renal secondary hyperparathyroidism. It's a really common but complex consequence of chronic kidney disease in our dogs and cats.
Definitely. Driven by that whole cascade. Failing kidneys can't clear phosphorus, phosphorus goes up, FGF23 goes up, calcitriol goes down, and PTH skyrockets.
Right. And that high PTH causes problems, especially for the bones, but potentially elsewhere too.
Yeah.
Diagnosing it relies on spotting the kidney disease signs, high phosphorus, but crucially measuring high PTH alongside low or normal ionized calcium.
Correct. And management hinges on controlling phosphorus through diet first, then adding phosphate binders if needed, and sometimes carefully using low-dose calcitriol, all under very close monitoring.
Yeah, that close monitoring seems absolutely vital, especially watching calcium and phosphorus levels to avoid complications like hypercalcemia or tissue mineralization.
It's non-negotiable, really. And while we might slow progression, the long-term outlook remains guarded because of the underlying CKD.
It really highlights how interconnected everything is, doesn't it? The kidneys impacting hormone levels, mineral balance, bone health.
It absolutely does. Which leads to maybe a final thought for everyone listening. Given this intricate link between kidney function and minerals, what other systems or processes in our pets' bodies, maybe ones we don't immediately think of, could also be significantly affected by chronic kidney disease?
That's a good point. It makes you think about the wider systemic effects of CKD beyond just the kidneys themselves.
Yeah. It really underscores why that regular monitoring and having open conversations with your vet about everything you're noticing is so incredibly important for comprehensive care.